Welcome to this comprehensive lecture on the diagnosis of CNS infections. CNS infections represent a neurologic emergency requiring prompt diagnosis and rapid initiation of targeted antimicrobial treatment. Although relatively rare compared to other sites of infection, CNS infections carry high morbidity and mortality, making accurate and timely diagnosis critical. This presentation covers the comprehensive approach to diagnosing CNS infections, including clinical manifestations, diagnostic methods, and specific pathogens. We will discuss the strengths and weaknesses of available diagnostic tests and how to choose the most appropriate specimen source and testing methodology. CNS infections affect populations worldwide. Although relatively rare compared to other sites of infection, they carry high morbidity, mortality, and long-term sequelae that make them a neurologic emergency requiring prompt diagnosis and rapid initiation of targeted antimicrobial treatment. A comprehensive approach to CNS infections should incorporate thorough history taking, neurologic examination, knowledge of pathogens endemic to the area of interest, and formulation of a differential diagnosis supported by imaging studies, serology, and CSF analysis when feasible. It is important to recognize the strengths and weaknesses of available tests for CNS infections, as well as the chosen source of specimen to choose the method most likely to yield an accurate result. James Leonard Corning first performed CSF analysis in 1885, which led to the performance of the first lumbar puncture by RT-QuIC a few years later. Robust identification and description of microorganisms followed at the turn of the 20th century and led to the description of the most common bacteria isolated from the CSF as a cause of meningitis. Viruses were harder to identify, the earliest reports suggesting herpes simplex virus as a causative agent of encephalitis in humans appeared in the 1920s. For the better part of the 20th century, histopathological diagnosis by visualizing the necrotizing characteristics of the virus on biopsy or autopsy remained the gold standard for diagnosis. The development of PCR in 1983 revolutionized the field of molecular diagnostics and was the cornerstone that led to the creation of monoplex real-time PCR assays, followed by multiplex PCR meningitis encephalitis panels, which are instrumental in rapidly diagnosing the most common CNS infections. The approach to a patient with suspected CNS infection begins with an attempt to identify the anatomical location of the inflammation, which may allow a targeted approach to determine the causative organism. CNS infections can be approached based on the presenting clinical syndrome, including meningitis, encephalitis, meningoencephalitis, space-occupying rim-enhancing lesions in the brain or spine, cerebrovascular involvement, myelitis, and myeloradiculitis. Certain microorganisms have specific tropism in the CNS. For example, herpes simplex virus typically affects the mesiotemporal lobes and insula. Listeria monocytogenes causes rhombencephalitis. West Nile virus causes deep brain lesions. Japanese encephalitis virus and toxoplasmosis also have characteristic patterns. Understanding these patterns helps guide the diagnostic approach and narrow the differential diagnosis. Bacterial meningitis is uniformly fatal if untreated. Even with treatment, it may cause acute hydrocephalus in 5% of patients, mainly communicating but rarely obstructive, and seizures in 17% to 50% of patients, especially in children with pneumococcal meningitis. Both hydrocephalus and seizures are poor prognostic factors and increase the risk of death. Other complications include cerebral edema, increased intracranial pressure, cerebral venous thrombosis, ischemic and hemorrhagic strokes, and subdural empyema. Long-term sequelae involve hearing loss, residual focal deficits, cognitive impairment, and epilepsy. The severity and acuity of CNS infections depend on the type of organism and the part of the CNS involved. Although viral meningitis is a much more benign process that is self-limited and seldom requires any antiviral treatment, viral encephalitis can lead to devastating consequences if not treated promptly, and even with appropriate interventions can leave permanent deficits. age above 65 years, a compromised immune system, a Glasgow Coma scale of 8 or less, and a need for intensive care unit admission and delay in initiating acyclovir are all poor prognostic factors for herpes simplex virus encephalitis. Among those who recover from herpes simplex virus encephalitis, up to 20% develop post-herpetic autoimmune encephalitis with antibodies to the N-methyl D-aspartate receptor that can mimic herpes simplex virus encephalitis relapse, typically between 2 to 6 weeks after initial diagnosis. CNS fungal infections are challenging to diagnose due to their rarity and can be life-threatening and have a fulminant course if not rapidly diagnosed. Cryptococcal meningoencephalitis is the most common fungal CNS infection and is fatal without treatment. Even with optimal care, the 3-month mortality approaches 20% in persons living with HIV and 20% to 30% of non-HIV, non-transplant patients. The diagnosis of CNS infections remains a challenge. A comprehensive approach should incorporate thorough history-taking, neurologic examination, knowledge of pathogens endemic to the area of interest, and formulation of a differential diagnosis supported by imaging studies, serology, and CSF analysis when feasible. It is important to recognize the strengths and weaknesses of available tests for CNS infections, as well as the chosen source of specimen to choose the method most likely to yield an accurate result. Establishing the etiology of neuroinflammatory diseases, whether infectious or autoimmune, is particularly challenging given the significant overlapping clinical and radiographic manifestations, which necessitate consideration of multiple tests and hypotheses simultaneously. History should include onset, course of illness, travel and exposures, drug use, sexual and dietary habits, immune status, competent versus compromised, recent vaccinations, animal contact, sick contact, seasonality, and geographic exposures to endemic diseases. The acuity and severity of CNS infections depend on the type of organism and the part of the CNS involved. Bacterial meningitis is uniformly fatal if untreated. Even with treatment, it may cause acute hydrocephalus in 5% of patients and seizures in 17% to 50% of patients, especially in children with pneumococcal meningitis. The neurologic examination is crucial in evaluating patients with suspected CNS infections. Key findings include meningeal signs such as neck stiffness, Koenig sign, and Brudzinski sign. However, these signs may be absent in certain populations such as infants, elderly patients, or immunocompromised individuals. Focal neurologic deficits may indicate encephalitis or space-occupying lesions. Altered mental status and confusion are common in encephalitis. Seizures may occur acutely or develop during the course of illness. Cranial nerve abnormalities may indicate specific pathogens such as facial nerve involvement in Lyme disease or oculomotor nerve involvement in tuberculous meningitis. The combination of clinical findings helps guide the differential diagnosis and directs appropriate diagnostic testing. CSF analysis is fundamental to the diagnosis of CNS infections. CSF should be obtained via lumbar puncture when there are no contraindications. Contraindications to lumbar puncture include signs of increased intracranial pressure, focal neurologic deficits suggesting mass effect, or imaging evidence of mass lesions. In these cases, neuroimaging should be performed before lumbar puncture. CSF analysis includes cell count and differential, glucose, protein, gram stain, culture, and molecular testing. The pattern of CSF abnormalities can help narrow the differential diagnosis. Bacterial meningitis typically shows elevated white blood cell count with predominance of neutrophils, elevated protein, and low glucose. Viral meningitis typically shows elevated white blood cell count with predominance of lymphocytes, normal or mildly elevated protein, and normal glucose. The CSF profile can help differentiate between bacterial, viral, and fungal infections. Bacterial meningitis typically presents with CSF white blood cell count greater than 1,000 cells per microliter with predominance of neutrophils, protein greater than 100 mgdl, and glucose less than 40 mgdl or CSF to serum glucose ratio less than 0.4. Viral meningitis typically presents with CSF white blood cell count between 10 and 1,000 cells per microliter with predominance of lymphocytes, protein between 20 and 100 mgdl, and normal glucose. Fungal meningitis typically presents with CSF white blood cell count between 20 and 500 cells per microliter, with predominance of lymphocytes, protein greater than 100 mg/dl, and low glucose. Tuberculous meningitis presents with CSF white blood cell count between 100 and 500 cells per microliter, with predominance of lymphocytes, very high protein greater than 200 mg/dl, and low glucose. Gram stain of CSF can rapidly identify bacteria and guide initial antibiotic therapy. However, sensitivity is limited, ranging from 50% to 90% depending on the organism and bacterial load. Culture remains the gold standard for bacterial identification and allows for antimicrobial susceptibility testing. However, culture results may take 24 to 48 hours or longer. Contamination of CSF samples can occur and must be distinguished from true infection. Repeat lumbar puncture may be necessary if initial CSF is contaminated. Viral cultures are less commonly performed due to low sensitivity and long turnaround time. Fungal cultures may take weeks to grow and are less sensitive than other diagnostic methods. Molecular testing has largely replaced culture for rapid diagnosis of common CNS pathogens. PCR-based molecular diagnostics have revolutionized the diagnosis of CNS infections. Multiplex PCR panels can simultaneously detect multiple common CNS pathogens, including bacteria, viruses, and fungi from a single CSF sample. Examples include the film array meningitis encephalitis panel, which can identify common bacterial pathogens, viruses, and fungi. PCR has several advantages over traditional culture methods, including rapid turnaround time, high sensitivity and specificity, and ability to detect non-viable organisms. However, PCR cannot determine antimicrobial susceptibility and may detect colonizing organisms or asymptomatic viral shedding. Positive PCR results must be interpreted in the clinical context. Negative PCR does not exclude CNS infection, particularly for organisms not included in the panel or for rare pathogens. Despite the promise of novel molecular diagnostic techniques incorporating multiplex nucleic acid amplification of common CNS pathogens, diagnosing CNS infections remains a challenge. Molecular testing has limitations that must be understood. PCR may detect organisms that are not the cause of CNS infection, such as colonizing bacteria or asymptomatic viral shedding. Negative PCR does not exclude CNS infection, particularly for organisms not included in the panel or for rare or unexpected pathogens. Emerging unbiased metagenomic sequencing may help identify rare or unexpected pathogens, but is not yet widely available. The clinical context, CSF profile, and imaging findings must be considered together with molecular test results to reach a diagnosis. Neuroimaging plays an important role in the diagnosis and management of CNS infections. MRI is preferred over CT for evaluating CNS infections due to superior soft tissue resolution and ability to detect subtle abnormalities. MRI findings can help localize the infection and suggest specific pathogens. Certain organisms have characteristic imaging patterns. Herpes simplex virus typically affects the mesiotemporal lobes and insula. Listeria monocytogenes causes rhombencephalitis with involvement of the brainstem. West Nile virus causes deep brain lesions. Toxoplasmosis typically presents with multiple ring-enhancing lesions in the basal ganglia and corticomedullary junction in immunocompromised patients. Tuberculous meningitis may show bacillar enhancement and hydrocephalus. Fungal infections may show minimal enhancement despite significant CSF abnormalities. CT imaging can be useful for rapid evaluation and detection of complications such as hydrocephalus, subdural empyema, or ventriculitis. However, Connecticut is less sensitive than MRI for detecting subtle parenchymal abnormalities. Specific imaging patterns can suggest particular pathogens. Bacterial meningitis may show enhancement of the meninges and possible complications such as hydrocephalus or subdural effusion. Viral encephalitis may show focal or multifocal abnormalities depending on the virus. Fungal infections may show minimal enhancement despite significant CSF abnormalities. Tuberculous meningitis may show bacillar enhancement, hydrocephalus, and spinal involvement. Imaging findings must be interpreted in conjunction with clinical presentation and CSF analysis. Serologic testing can be useful for diagnosing certain CNS infections, particularly viral infections. Serum and CSF antibodies can be detected for many viral pathogens, including measles, mumps, rubella, West Nile virus, and arboviruses. CSF-specific antibodies are more specific for CNS infection than serum antibodies. Paired acute and convalescent serum samples can demonstrate seroconversion, confirming recent infection. However, serologic testing may be negative early in infection before antibodies develop. In immunocompromised patients, antibody responses may be blunted or absent. Serologic testing is often used in combination with other diagnostic methods such as PCR and CSF analysis. The interpretation of serologic results must consider the clinical context and timing of testing. Proper specimen collection and handling are critical for accurate diagnosis of CNS infections. CSF is the preferred specimen for most CNS infections as it directly reflects CNS pathology. However, in some cases, serum or other specimens may be useful. The choice of specimen depends on the suspected pathogen and the clinical context. CSF should be collected via lumbar puncture under sterile conditions. Multiple tubes should be collected to allow for cell count, culture, molecular testing, and other studies. CSF should be processed promptly to avoid cell degradation and false results. Serum can be useful for serologic testing and detection of certain pathogens such as arboviruses. Respiratory specimens may be useful for detecting respiratory viruses that can cause CNS infection. Blood cultures may be positive in bacterial meningitis and can guide antibiotic therapy. The most common bacterial causes of meningitis vary by age and risk factors. In adults, Streptococcus pneumonia and Neisseria meningitis are the most common causes. Listeria monocytogenes is more common in elderly patients and immunocompromised individuals. Gram-negative organisms such as Escherichia coli and Klebsiella pneumoniae are more common in neonates and patients with CSF shunts. Group B Streptococcus is common in neonates. The clinical presentation, CSF profile, and imaging findings can help guide the differential diagnosis. Empiric antibiotic therapy should be initiated promptly based on clinical suspicion before culture results are available. Antimicrobial susceptibility testing guides definitive therapy. The most common viral causes of meningitis and encephalitis include herpes simplex virus, enterovirus, and arboviruses such as West Nile virus. Herpes simplex virus typically causes encephalitis with characteristic involvement of the mesiotemporal lobes. Enterovirus causes a more benign meningitis that is self-limited. West Nile virus causes encephalitis with deep brain involvement. Other viral pathogens include mumps, measles, varicella zoster virus, and cytomegalovirus, particularly in immunocompromised patients. The clinical presentation, CSF profile, and imaging findings help guide the differential diagnosis. Molecular testing with PCR is rapid and sensitive for detecting viral pathogens. Antiviral therapy should be initiated promptly for herpes simplex virus and other treatable viral infections. Fungal CNS infections are less common than bacterial or viral infections, but are important to recognize due to their high morbidity and mortality. Cryptococcus neoformans is the most common fungal cause of meningitis worldwide and is particularly common in immunocompromised patients. Coccidioides immitis causes meningitis in endemic areas such as the southwestern United States. Histoplasma capsulatum causes meningitis in endemic areas. Other fungal pathogens include Blastomyces dermatitidis, Aspergillus species, and Candida species. CSF analysis typically shows lymphocytic pleocytosis, elevated protein, and low glucose. Fungal cultures may take weeks to grow. Antigen detection and molecular testing can provide more rapid diagnosis. Antifungal therapy should be initiated promptly based on clinical suspicion. Parasitic CNS infections are less common in developed countries but remain important causes of CNS infection worldwide. Toxoplasma gondii causes encephalitis in immunocompromised patients, particularly those with CD4 count less than 100 cells per microliter. Cystic sarcosis caused by Taenia solium is a common cause of seizures worldwide. Cerebral malaria caused by Plasmodium falciparum can cause severe encephalopathy. Other parasitic pathogens include Trypanosoma brucei, causing African sleeping sickness, and Entamoeba histolytica, causing amoebic meningoencephalitis. Diagnosis often relies on imaging findings and serologic testing, as CSF parasites may be difficult to detect. Treatment depends on the specific parasite and may require prolonged therapy. Tuberculous meningitis is a severe form of CNS infection with high morbidity and mortality. It typically presents with subacute symptoms over days to weeks. CSF analysis typically shows lymphocytic pleocytosis, very high protein, and low glucose. Acid-fast bacilli may be detected on Zeal-Nielsen stain, but sensitivity is low. Culture is the gold standard, but may take weeks. Molecular testing with PCR can provide rapid diagnosis. Imaging may show bacillar enhancement, hydrocephalus, and spinal involvement. Tuberculin skin test and interferon gamma release assay may support diagnosis but are not specific for CNS disease. Anti-tuberculous therapy should be initiated promptly based on clinical suspicion. Several atypical and rare pathogens can cause CNS infections. Borrelia burgdorferi causes Lyme meningitis and neuroborreliosis. Treponema pallidum causes neurosyphilis, including meningitis and meningovascular disease. Leptospira causes aseptic meningitis. Brucella causes meningoencephalitis. Bartonella henselae causes cat scratch disease with CNS involvement. Diagnosis often relies on serologic testing and CSF analysis. Some organisms have characteristic clinical presentations that facilitate diagnosis. Treatment depends on the specific pathogen and may require prolonged antimicrobial therapy. Recognition of these pathogens is important, as they may not be detected by standard multiplex PCR panels. Immunocompromised patients are at increased risk for CNS infections, including opportunistic infections that would be rare in immunocompetent individuals. Patients with HIV and low CD4 count are at risk for cryptococcal meningitis, toxoplasmosis, progressive multifocal leukoencephalopathy, and cytomegalovirus infections. Transplant recipients are at risk for infections with opportunistic pathogens. Patients receiving chemotherapy or immunosuppressive therapy are at risk for fungal and other opportunistic infections. The differential diagnosis in immunocompromised patients is broader and requires consideration of unusual pathogens. CD4 count and immune status guide the differential diagnosis and risk stratification. Prophylactic therapy may be indicated for certain infections in patients with severe immunosuppression. CNS infections can cause several acute complications that increase morbidity and mortality. Hydrocephalus can develop due to obstruction of CSF flow or impaired CSF absorption. Seizures occur in 17% to 50% of patients with bacterial meningitis, particularly in children with pneumococcal meningitis. Increased intracranial pressure can result from cerebral edema, hydrocephalus, or ventriculitis. Cerebral venous thrombosis can occur and cause stroke. Subdural empyema is a collection of pus between the dura and arachnoid and requires urgent drainage. Ventriculitis is inflammation of the ventricular system and is associated with worse outcomes. Recognition and management of these complications is critical for improving outcomes. CNS infections can result in long-term sequelae that significantly impact quality of life. Hearing loss is one of the most common sequelae of bacterial meningitis, occurring in 5% to 30% of survivors. Cognitive impairment and memory problems occur in a significant proportion of survivors. Residual focal neurologic deficits, such as hemiparesis or cranial nerve palsies, can occur. Epilepsy develops in 10% to 20% of survivors of meningitis. Post-herpetic autoimmune encephalitis can develop weeks after initial herpes simplex virus encephalitis. Post-infectious autoimmune encephalitis can develop after various CNS infections. Long-term follow-up and rehabilitation are important for optimizing outcomes in survivors of CNS infections. Prompt initiation of antimicrobial therapy is critical for improving outcomes in CNS infections. Empiric therapy should be initiated based on clinical suspicion before culture results are available. The choice of empiric therapy depends on patient age, risk factors, and local epidemiology. Common empiric regimens include ceftriaxone or cefotaxime plus vancomycin for bacterial meningitis. Acyclovir should be added if herpes simplex virus encephalitis is suspected. Definitive therapy is guided by culture results and antimicrobial susceptibility testing. Adequate CNS penetration of antimicrobial agents is critical. Some agents penetrate the inflamed meninges better than others. Duration of therapy varies depending on the pathogen and clinical response. Adjunctive dexamethasone may improve outcomes in bacterial meningitis. Prevention of CNS infections is important for reducing disease burden. Vaccines are available for several bacterial pathogens, including Streptococcus pneumoniae and Neisseria meningitidis. Vaccination recommendations vary by age and risk factors. Chemoprophylaxis may be indicated for close contacts of patients with meningococcal meningitis. Antiretroviral therapy and immune reconstitution reduce the risk of opportunistic CNS infections in HIV-infected patients. Prophylactic antifungal or antimicrobial therapy may be indicated for patients with severe immunosuppression. Public health measures such as respiratory isolation of patients with meningococcal disease help prevent transmission. Education about symptoms and prompt medical evaluation can facilitate early diagnosis and treatment. Emerging diagnostic technologies promise to improve the diagnosis of CNS infections. Unbiased metagenomic sequencing can detect rare or unexpected pathogens not included in standard multiplex PCR panels. This technology may be particularly useful for patients with negative standard testing but persistent clinical suspicion. Rapid immunoassays and point-of-care testing may allow faster diagnosis in resource-limited settings. Biomarkers in CSF and serum may help differentiate bacterial from viral infections and predict outcomes. Integration of multiple diagnostic modalities, including imaging, CSF analysis, molecular testing, and clinical data using artificial intelligence may improve diagnostic accuracy. However, these technologies are not yet widely available and require further validation. A systematic approach to diagnosing CNS infections improves diagnostic accuracy and patient outcomes. The first step is clinical suspicion based on history and physical examination. Neuroimaging should be performed to exclude contraindications to lumbar puncture. Lumbar puncture should be performed when there are no contraindications to obtain CSF for analysis. CSF analysis, including cell count, glucose, protein, gram stain, and culture, should be performed. Molecular testing with multiplex PCR should be performed for rapid pathogen identification. Blood cultures should be obtained in patients with suspected bacterial meningitis. Serology may be useful for certain viral pathogens. Empiric antimicrobial therapy should be initiated promptly based on clinical suspicion. Definitive therapy is guided by culture results and antimicrobial susceptibility testing. CNS infections in neonates present unique diagnostic challenges due to non-specific symptoms and different pathogen epidemiology. Group B Streptococcus and Escherichia coli are the most common bacterial causes in neonates. Herpes simplex virus can cause severe disseminated infection in neonates. Cytomegalovirus can cause congenital infection with CNS involvement. Maternal antibodies may complicate serologic interpretation. Lumbar puncture may be more difficult technically in neonates. CSF parameters may differ from older children and adults. Empiric therapy typically includes ampicillin plus gentamicin plus cefotaxime to cover group B streptococcus, gram-negative organisms, and listeria. Acyclovir should be added if herpes simplex virus is suspected. Close follow-up for developmental assessment is important. CNS infections in elderly patients may present atypically with non-specific symptoms such as confusion or delirium without fever or meningeal signs. Listeria monocytogenes is more common in elderly patients. Gram-negative organisms and Streptococcus pneumonia remain common causes. Underlying comorbidities may complicate diagnosis and treatment. Empiric therapy should include coverage for listeria with ampicillin in addition to cephalosporin and vancomycin. Prognosis is generally worse in elderly patients due to delayed diagnosis and underlying comorbidities. Careful attention to drug interactions and renal function is important when selecting antimicrobial therapy. Immunocompromised patients, including those with HIV, transplant recipients, and patients receiving immunosuppressive therapy, are at risk for CNS infections with opportunistic pathogens. CD4 count in HIV-infected patients helps predict risk of specific infections. Cryptococcal meningitis risk increases significantly when CD4 count falls below 100 cells per microliter. Toxoplasmosis risk increases when CD4 count falls below 100 cells per microliter. Progressive multifocal leukoencephalopathy risk increases when CD4 count falls below 200 cells per microliter. Cytomegalovirus infections occur with CD4 count below 50 cells per microliter. The differential diagnosis is broader in immunocompromised patients and requires consideration of unusual pathogens. Immune reconstitution with antiretroviral therapy or reduction of immunosuppression may improve outcomes. Several common diagnostic pitfalls can lead to delayed or missed diagnosis of CNS infections. Failure to perform lumbar puncture in patients with suspected meningitis is a critical error. Misinterpretation of CSF parameters can lead to incorrect diagnosis. Contamination of CSF samples can lead to false positive cultures. Over-reliance on negative molecular testing without clinical correlation can lead to misdiagnosis of rare pathogens. Failure to consider immunocompromised status and risk for opportunistic infections can lead to delayed diagnosis. Inadequate empiric therapy coverage can result in treatment failure. Failure to recognize complications such as hydrocephalus or subdural empyema can result in poor outcomes. Awareness of these pitfalls and systematic diagnostic approach can help avoid errors. A 45-year-old previously healthy man presents with fever, severe headache, and neck stiffness for 12 hours. On examination, he has fever, neck stiffness, positive Koenig and Brudzinski signs, and altered mental status. CT head is normal. Lumbar puncture shows CSF with white blood cell count of 2,500 cells per microliter with 90% neutrophils, protein of 250 mg/dl, and glucose of 30 mg/dl. Gram stain shows gram-positive diplococci. Blood cultures are positive for Streptococcus pneumonia. Empiric therapy with ceftriaxone and vancomycin was initiated immediately. Culture and susceptibility testing guide definitive therapy. The patient recovers with appropriate treatment but develops hearing loss as a long-term sequela. A 32-year-old woman presents with fever, confusion, and seizures for 3 days. On examination, she has fever, altered mental status, and focal neurologic deficits. MRI shows T2 hyperintensity in the left mesiotemporal lobe and insula with associated diffusion restriction. CSF analysis shows white blood cell count of 150 cells per microliter with predominance of lymphocytes, protein of 80 mg/dl, and normal glucose. Gram stain and culture are negative. PCR for herpes simplex virus is positive. Acyclovir was initiated immediately. The patient recovers with appropriate treatment but develops memory impairment as a long-term sequela. A 38-year-old man with HIV and CD4 count of 25 cells per microliter presents with subacute headache and fever for 2 weeks. On examination, he has fever but minimal meningeal signs. CT head shows no acute abnormality. Lumbar puncture shows CSF with white blood cell count of 50 cells per microliter with predominance of lymphocytes, protein of 150 mg/dl, and glucose of 30 mg/dl. Cryptococcal antigen is positive in both CSF and serum. Fungal culture grows Cryptococcus neoformans. Amphotericin B was initiated. The patient improves with appropriate treatment and immune reconstitution with antiretroviral therapy. Ensuring diagnostic accuracy in CNS infections requires adherence to quality standards and best practices. Proper specimen collection and handling are critical. Contamination of CSF samples must be minimized through sterile technique. Rapid processing of specimens preserves cell viability and improves diagnostic accuracy. Laboratory quality assurance programs should include proficiency testing and regular review of results. Clinical laboratories should participate in external quality assurance programs. Communication between clinicians and laboratories is important for appropriate test selection and result interpretation. Standardized reporting of results facilitates clinical decision-making. Periodic review of diagnostic accuracy and outcomes helps identify areas for improvement. Diagnosis of CNS infections requires a comprehensive approach incorporating clinical suspicion, thorough history and physical examination, appropriate diagnostic testing, and clinical correlation. CSF analysis remains fundamental to diagnosis. Molecular testing with multiplex PCR provides rapid identification of common pathogens. Neuroimaging helps localize infection and detect complications. Empiric antimicrobial therapy should be initiated promptly based on clinical suspicion. Definitive therapy is guided by culture results and antimicrobial susceptibility testing. Recognition of complications and long-term sequelae is important for optimizing patient outcomes. Awareness of diagnostic pitfalls and systematic approach to diagnosis improves diagnostic accuracy. Continued education and adherence to best practices ensure optimal care for patients with CNS infections.